Assalamu alaikum, everyone. Welcome to the Neurosurgical Case Room. I am audible, right?
Yes, you are.
Thank you. Please, everyone, mute yourself. Do not unmute until unless you have to ask any question. Let's begin. So it was totally on me. I completely forgot that we have not finished the sphenoid wing meningiomas, and I directly jumped over to Sylvian Fisher. But I think by this point, all of you are well versed in the anatomy of the clinoidal region, the sphenoid region, and the Sylvian Fisher and the areas around it. So it won't take much long, inshallah ta'ala. Let's just go over briefly over what we covered in the previous session so that anybody who did not attend the previous one will have some idea. And then we will move on to the clinical presentation and the surgical nuances, which were the only thing that were remaining. So the relevant anatomy, do I need to go over the relevant anatomy? But be honest, if you think you need the help, then that's okay.
Yes.
Okay, so this is an individual section of the sphenoid bone, and we have thoroughly discussed this anatomy. This is the lesser wing of a sphenoid. We are going to mark it on the both sides. They are following, and at the most medial edge, they are followed by a bony projection on both sides, which are called anterior clinoidal processes. We know this. Anterior clinoidal processes in the middle have this tuberculum sella here. Just behind the tuberculum sella, this is here, this is called optic groove, but it is also called chiasmatic sulcus. Just behind the chiasmatic sulcus, we have here the limbus sphenoidal. Behind the limbus sphenoidal, this region is called the planum sphenoidal. Right? This is easy so far. Under the anterior clinoidal process, if we have an anterior view, I think we have another image. There is this bony bar, which is the optic strut. I'm going to draw this. We have the optic canal here. We have the anterior clinoidal process here, and then we have the superior orbital fissure here. There's this bar here, which is called the optic strut. It separates the optic canal and the superior orbital fissure. We have thoroughly discussed this before as well. But just so you know, once we are doing the anterior clinoidectomy, we also remove the optic strut and we unroof the optic canal here. So if we are talking surgically, I'm going to mark the area that we need to remove. If the optic nerve is getting compressed, then we take the roof of the optic nerve as well. We remove this anterior clinoidal process, and then we also remove the optic strut, which is inferiorly slightly, and we cannot see it at the present. We clear all of this. If we go slightly posterior, this is not actually posterior. It's what you're seeing is a slightly superior and anterior view. If you look at it in its natural anatomic position, this is the superior view, right? You are seeing the tuberculum sella here. Just a minute. Let me change the color. This is the tuberculum sella, and this is the dorsum sella. And in between, we have the sella turcica, and over here goes the diaphragma sella, in between which we have the stalk or the infundibulum of the pituitary. On these sides, if you look closely on the lateral sides, there is this groove here, which is not marked on this image. No, I don't think it is marked here, but this groove is the groove for the ICA. We know that the cavernous ICA travels on the lateral side of this portion, and then it goes slightly here in this region where I'm drawing right now, and to this region, this is extradural internal carotid artery, and then it crosses the clinoid to pierce the dura. We are clear on it so far. On the lateral sides, we also have the cavernous sinuses, in which we have the ICA, the cavernous ICA, along with we have the cranial nerve 3, 4, 6, and V1. So all these nerves and the ICA are running in the cavernous sinuses. On the lateral side, we have these. This is the clivus here. Please mute yourself. So this is clivus here. This has been cut. Half of the clivus is made by sphenoid. Rest of the half, which is the inferior half, is made by basal occiput. So clivus is contributed by two bones. It looks like a slide on the sagittal section. It goes like this. So the inferior most portion is made by, excuse me, it's made by occiput, occipital bone, and the superior portion is made by sphenoid bone. So what you're seeing here is the continuation. Then on the lateral side, this region is going to correlate with the petrous apex of the temporal bone. And we are not going in the detail because we have thoroughly covered these in the previous sessions. This is petrous apex. Right around this petrous apex, we are going to have Meckel's cave. Let me draw this. We have Meckel's cave here, out of which three branches of the trigeminal nerve come. This is foramen ovale, V3 goes here. This is foramen rotundum, V2 goes here. And through superior orbital fissure, V1 goes. So once, you would need to imagine this, when we are going extradurally, and we retract the temporal lobe along with its dura, and we look at the base of skull. This is the middle cranial fossa. We look at the middle cranial fossa. On the base, we are going to find the trigeminal nerve branches coming out of the Meckel cave, going into these foramen. And if we retract the temporal lobe laterally enough, we can access these nerves outside. Okay, clear? All of this, I think relevant anatomy is pretty clear. Let's move on. You can see it in its complete position now. And you can also see now why I said that this region is connected by the petrous apex. We are going to have Meckel's cave right around here so that the branches go like this. And in this image, you can also see the clivus, which is now completed. The lower portion is made by occipital bone. The superior portion is made by the sphenoid bone. And yes, the anterior clinoidal process, it's drilled along with the lesser wing of sphenoid. Some portion of the greater wing of sphenoid can be drilled if needed or if it is hyperstosed. But usually the part that we drill is the lesser wing of sphenoid. All of this, we have discussed it very, very thoroughly. What you see here is an illustration of the structures that we have discussed. The only structures that we did not are third, cranial nerve 3. We have the PCOM here, along with the optic nerves that make the chiasm, and posteriorly they go as optic tracts. Please mute yourself. I should not be having to say this again and again. So we have ICA. ICA is dividing itself into ACA anteriorly here. And on this side, there is going to be MCA. So what you see here is the ICA bifurcation as well. Clear all of this and move to the next slide. So this is all the similar structures, similar images. All we have is the diaphragma sella and the pituitary localization as well. So now you know what structures are you going to anticipate here while you're doing the surgery. What structures will you anticipate during the clinical presentation? Because if you know the surrounding structures, clinical presentation is just a breeze that we pass through. This is the inferior surface of the brain. We have thoroughly discussed this in all these recent sessions because we covered this in the Sylvian fissure sessions as well, the temporal sessions as well. What you see here is the anterior perforating substance on both sides. We have the optic tracts here, and we have the mammillary bodies. And this is the pituitary. These are the optic nerves. These are the olfactory bulbs on both sides. What you see here is the inferior surface of the temporal lobe that we also have discussed thoroughly. So I am not going to go in the details, but you should keep this in your mind that when we are discussing sphenoid wing meningiomas, either the lesion is going to be somewhere around here, or it may be here, or here. So all these structures can get involved, and the presentation is going to be according to the involvement of these structures. We have done these, so I'm not going to go over them. There's this classification. There are two main classifications. One is the Cushing and the Eisenhardt, the one that we ratify during the rounds that is asked. It's also the most common one. Medial or clinoidal, which is the inner third of the ridge. Then we have middle or alar, which is the central portion of the ridge. And then we have lateral. I don't think I even need to draw this, but it's okay. Let's start here. So this portion is going to be the medial. This portion is going to be the middle, and this portion is going to be the lateral. Obviously, the structures that are going to be encountered are completely different. Once we talk the medial sphenoid wing meningiomas or the clinoidal meningiomas, we have dedicated sessions on them since Mefty treats them as individual identities. But we know that for medial ones, ICA can get involved, optic nerve can be involved, oculomotor nerve can also be involved here, then superior orbital fissure structures, then cavernous sinus structures, and very less likely, but sometimes the early portion, the very proximal portion of MCA as well, but that is less likely. Sometimes this also ends up growing more medially, and it can cause compression on the stalk, and sometimes there can be sellar extension as well. It's rare, but it is possible. When we are talking about the middle one, this is the alar. Alar in the tumors that are alar primarily. Yes, Dr. Fatma, I'm so glad that you're back. And yes, MCA involvement proximal. If we are talking about the medial most meningiomas, proximal MCA can get involved. Then we have the alar lesions. For alar lesions, we know what is here. There's going to be MCA, which crosses around here. That can get involved. MCA bifurcation especially. Along with that, sometimes now then depends which direction the tumor is growing on. It can cause compression over the temporal lobe, so the patient can present with seizures. It can also extend anteriorly to the anterior cranial fossa and the frontal lobe. The compression is going to be dependent on the tumor location and the direction of its growth. Then we have the lateral ones. The lateral ones are the only structures we are worried about here are the MCA, especially the distal branches. Along with that, the bone could be hyperostomosed or the bone could be thinned out. Sometimes in these sphenoid wing meningiomas, we end up feeling this lump under the temple, or there's this visible mass that is protruding because the bone has been lysed completely and the mass is visible or palpable. Any of these lesions, if they are inducing hyperostosis of the bone, then any of these lesions can present with exophthalmos with unilateral proptosis. It can also present with superior orbital fissure involvement and optic nerve compression. That is less common on the lateral side. It's more common on the alar and in the medial. Then we also have a type which is called sphenoorbital. We are going to discuss it later on. So the other classification is Bonnell classification. We have discussed this thoroughly. I'm going to go over it very briefly. We have 5 groups. Group A is the clinoidal. Group B is the sphenoorbital, which is the on-plaque tumors. They are usually you will not find these tumors in a globular form. They will be on plaque. They will be grossly causing bony hyperostosis around the sphenoid wing and the orbital roof, sometimes even the walls of the orbit. Then we have group C. These are invasion en masse, and these are French words. And they just mean that this lesion is invading massively. These are large tumors. And they have both components, the globular component and the invasive on-plaque features. Then we have the group D, they are globular tumors of the middle ridge, and E, they are the lateral ridge. So the classification, yes, Dr. Subham, sphenoid wing meningioma classically presents with unilateral proptosis. So the previous classification that we discussed, which was the Cushing and Eisenhardt, according to that, the clinoidal tumors, which were the medial ones, they are group A. The middle or the alar ones, they are group D. And the lateral ones or the convexity or the terional, these are the group E. B and C are the additions that were not in the Cushing's classification. Group B is the sphenoorbital. These are on plaque, and group C is globular plus invasive on plaque. So you're going to find a mass, a lump. Along with that, you're also going to find this sheet-like invasion of the dura. So remember the classification because we are going to see the images now. So which one would be this?
B. B. B.
Which one is this?
Bombay. Beef B.
B.
YB?
It is
YB
in plaque. It is in plaque.
could be classified as globular, but it looks like on plaque. And if you see, it is also involving the lateral portion of the orbit. So it is a sphenoorbital meningioma. You can see there's significant hyperostosis going on here on the other side. And even the anterior clinoidal process is hyperostosed. So it is B. You were right. I never said that you were wrong. I just wanted you to stand on your answer and explain why you said that. So this one is easy. Which is this one? If you follow my cursor, let's mark it. Which is this one?
A.
Oh, I did not mean to write the answer. All I meant to write was like this is image A and this is image B so that it's easier for you to answer. But yes, this is type A or group A as well. It's a clinoidal meningioma. And the other one is B. Interestingly, the image grading that I was doing was also helping you answer, so that's okay. Which is this one?
D.
Take a look again.
Globular middle ridge.
LR.
This is
Yes. So, what did you say? Did you say D or did you say B? Who was this?
D.
Yes, this is D. This is D. This is Eller. And this is D. Okay. Let's move. This is the easiest one, right? Which is this one?
Terional or lateral.
Yes. So what group that would be?
E.
E. That's right. So, lateral meningiomas, they are located on the outer third. Presentation is often with the calvarial bulging. We did that. Painless fructosis can be a typical presentation. The problem with these lesions is since they are far away from the more critical neurovascular structures, they often end up presenting very late. Since there's a lot of space, they can grow big enough before they cause actual problems for the patient. The patient usually comes when there's significant compression on the temporal lobe, and patient either starts having memory impairment or patient might have new onset seizures, or sometimes with the calvarial lump that I talked about. We move. With the middle sphenoid wing meningiomas, they are Eller. These lesions are just like their location, they are also intermediate in terms of their severity. They are not so close to the neurovascular structures which are critical, but they are also not too far. So also the place they are in, the ICP is going to be raised disproportionately because the space is a lot tighter than the lateral side of the calvaria. So they can present with seizures. They can also present with frontal lobe signs. if the lesion is, growing into both the anterior and the middle cranial fossa. Yes, there's this term which is called straddling. So if it is straddling the lateral side, then it can compress both the frontal and the temporal lobe. We are going to discuss the presentation, but I'm just going to I'm just giving you some ideas so that you can distribute the clinical presentation according to the location. Medial meningiomas, they are often earliest to present, especially if they are anywhere near the optic nerve, because the patient is going to present with decreased visual acuity. You will have primary optic atrophy on fundoscopy, and these are also the hardest ones because they are very close to optic nerve. They're also close to ICA, and complete resection is often not possible. There are some authors that divide medial sphenoid wing meningiomas into clinoidal and suprasellar types as well. So we did the neurovascular involvement, and we also did the presentation. Beyond that, we know that meningiomas can be classified morphologically as well. We have the globular ones, well-circumscribed rounded masses. We have the on-plaque ones, which are diffuse sheet-like growth. And these have the potential to induce significant hyperostosis within the bone. And we are not going to do the relationship of Sylvan fissure, but let's come to the clinical presentation. One of the commonest clinical presentations of sphenoid wing meningiomas is going to be symptoms related to vision. It can be decreased visual acuity, it can be diplopia, it can be field defects, depends on the site of the lesion, depends on the involvement as well. Foster-Kennedy syndrome is not typically associated with sphenoid wing meningiomas. It is
Olfactory group.
usually, please mute yourself.
Olfactory.
Are you trying to say something?
Madam, Foster Kennedy may be because of olfactory group meningioma.
Foster-Kennedy syndrome is the typical presentation of olfactory groove meningiomas. You're right, but it can present in sphenoid wing meningiomas where there is compression on single side of optic nerve, and there's significant ICP which is causing contralateral papilledema. And so if clinically you're seeing Foster-Kennedy syndrome, it's very unlikely that a patient will present with this. But you can see it. That does not mean that you can see it. What is Foster-Kennedy? Foster-Kennedy means that there is direct compression on the optic nerve and there is indirect compression or raised ICP on the other side. So it's not typical for sphenoid wing, but it is a possible presentation. Then we have diplopia. We did that. After that, exophthalmos, we just discussed. It is a classic presentation for sphenoid wing meningiomas. Clear, and move to the next one. Trigeminal nerve deficits usually are not, reported by the patients. Sometimes if someone is very meticulous about their own presentation, they will tell you. You might find it, but it's something that you should know and keep in your mind while you're evaluating a patient for sphenoid wing meningioma, but it is not common. Oculopalsies are obviously a possibility if the superior orbital fissure is involved. Then we have seizures. Seizures can be completely temporal type. They can be complex partial uncinate seizures because of the temporal lobe irritation. They can also be due to irritation of the frontal lobe if the lesion has grown above. Motor and speech deficits. Why? Because we have thoroughly discussed. There is Broca's area right here. Let me go back and show you that image. So I think all of you will find this image really, really easy. We have done this super thoroughly. This is the posterior ramus of the Sylvan fissure. What we see here is the anterior Sylvan point. And just above it, if you see, we have the pars triangularis here. And there is going to be Broca's region, this portion. So if there is a lesion here, because this is going to be the location, when I say that a tumor can straddle both the middle cranial fossa and the anterior cranial fossa. This is what I mean. A lesion which is growing like this. So it's going to cause compression on the temporal lobe, but it is also going to cause compression on the frontal lobe, which if it is dominant, then it is going to directly involve Broca's. So the patient can also present with language disturbances. Move. Motor deficits are pretty self-explanatory. If the lesion is growing slightly posteriorly involving the precentral gyrus, motor deficits are the likely possibility. Cognitive changes and psychological changes are dependent on how much the frontal lobe is affected and how much of the mass effect there is. Patients can present with depressed mood, with apathy, with decreased inhibition, psychiatric symptoms. So essentially, sphenoid wing meningiomas, their clinical presentation is a salad bowl. You pick and choose according to the location and the patient. This is important. The vessels that they use to feed, they are important because we need to know once we are operating on these patients. Lesions of the middle sphenoid bridge, we know that since they're in close vicinity of the ICA, they can have direct feeders. They can also have feeders by ascending pharyngeal artery and sometimes a recurrent branch of the ophthalmic artery. Lateral tumors, they can drive supply from the superficial temporal and from the middle meningeal artery. Hence, when we are doing the extradural work, the extradural dissection during the surgery, we coagulate the middle meningeal artery before we even open the dura. Dr. Ibe, you are writing on my screen. So the additional feeding vessels, they may include in the anterior meningeal artery, sometimes branches of ethmoidal artery as well.
So during surgery, where to tackle this arteries before the dissection?
Depends. If the artery is a branch of the ECA, then you can tackle it, you can coagulate it. It's not going to cause much risk. If they are branches of the internal carotid artery, it's a good idea to stay away. For the diagnostic workup, we need MRI brain with contrast. Fat suppression images are done when there is orbital extension or when there is carinous sinus involvement. We also need high resolution CT. Why? Because we want to see bony hyperostosis. Bone invasion, we want to see if optic nerve is narrowed, if the anterior clinodal process is hyperostosed. Sometimes some surgeons may also choose to get 3D reconstruction so that they can plan the craniotomy accordingly. And especially if they are going to open the orbital roof or the lateral wall of orbit. CT or MRI is usually not needed until and unless the lesion is very medial, because T2 weighted images are going to be sufficient in usual cases until and unless it is Dr. Subham, endovascular embolism of the feeders is possible if they are not from ICA. If they are from ICA, we avoid it usually. It is only possible if it is for ECA. So CTA or MRA is done if we think that there is encasement of ICA and MCA. If we do not see visible encasement, then T2 weighted image is going to be sufficient usually. We know that the patient is going to need complete visual workup. We are going to need fundoscopy. We are going to need a visual field testing. We will need a formal ophthalmological review, not only for the clinical purposes. We are also going to need it for the litigation as well. Also, you need to, I think we have discussed such a case before. If a lesion is a medial sphenoid wing meningioma or a clinoidal sphenoid wing meningioma, we have to keep the possibility of cellular invasion and the compression of pituitary stalk or the hypothalamus, because patient can have DI, patient can have hypothalamic dysfunction, and If we do not anticipate this preoperatively, then it will be really, really difficult to counsel about this postoperatively to the patient. And if there is compression on pituitary sac, what is going to happen? What is that effect called?
Stroke effect.
That's right. So stock effect, very less likely, but it is a possibility. So if you are looking at an image where there is involvement of sella or very close vicinity of sella, then it's always a good idea to get prolactin so that you can be sure if there is a stock effect in the labs. Clear this. The surgery part for sphenoid wing meningiomas is easier in comparison with the clinoidal meningiomas because obviously the structures, they are not as critical apart from MCA. Maybe if MCA is encased, then that is a different scenario. So our goal is going to be complete resection. GTR is the goal here as opposed to clinoidal meningiomas. We go with the idea that we are going to get the tumor completely out because that is the cure. Until and unless it is involving the MCA or it is involving the optic nerve or the sphenoid, superior orbital fissure or the cavernous sinus, the no-go areas. Apart from that, we are going to plan a GTR. Craniotomy is the normal frontotemporal craniotomy that we do. We drill the pterion. We also drill the lesser wing of a sphenoid. For devascularization, because somebody asked this, for devascularization, we coagulate the branches which are coming from the external carotid artery, like the middle meningeal artery, etc., etc. We coagulate it. For ICA, any feeders that are directly from ICA, we are very, very careful. And we need to make sure if they are actually the perforators or they are just passing through that region. Because, let me just draw. If this is a lesion, and you see that there is a vessel that is ending here, that might be a feeder. But if you end up missing the hairpin bend that it makes at times, and this same vessel is coming outside and there's this hairpin bend, and then you end up coagulating, then you risk this vessel unnecessarily. It would not have been a true feeder. So it's very important when you are very close to the ICA to be sure what vessels you are coagulating. Bipolar is your best friend, and bipolar is also your worst enemy if you're not very careful with it. We move. For the meningiomas, we have the standard techniques. We do the devascularization, then we do the internal decompression. We maintain the arachnoid plates. And while we are dissecting these lesions away from the vessels, we try maintaining the arachnoid planes. If we do not find the arachnoid planes, it's always a good idea to leave this rim of lesion around that vessel instead of sacrificing the vessel. Also, CUSA is not a good idea along or in the vicinity of major vessels because CUSA can, nick the wall of the vessel. So apart from that, dissection is always a good idea. Maintain the arachnoid planes. Avoid CUSA when you're working in the vicinity of MCA or even the distal branches. When we are talking about MCA, the goal is to go from distal to proximal. Instead of, trying to find proximal MCA blindly, what we do is we track the distal branches and we slowly peel the tumor off. We go back and we follow this vessel, and the distal branch is going to be our map to the main trunk of MCA. If you try looking for the main trunk directly, it might end up being disastrous. So we already have discussed the superior orbital fissure is a difficult region when we talk about GTR. Cavernous sinus is also a difficult region. There are authors that say If meningioma is within the cavernous sinus, then GTR is precluded. Send the patient for SRS postoperatively. But there are certain authors that say if the tumor is still following the arachnoid planes, then you can take it out from the cavernous sinus, especially the lateral cavernous sinus. So there are differences of opinion on this. For us, I think when we are talking about the early professional stages, I think not going very near the cavernous sinus is always the good idea. The patient stays safe and you also stay safe. For the residual lesion, we try coagulating them if we cannot completely take out the dura. The dural repair is going to be meticulous because there is going to be this huge gap on the skull base for which you will use the pericranial grafts. You can use the fascia lata or the pericranium itself. You can use artificial grafts. So it depends on your institutional setup and availability. And you suture it. After suturing, you use this fibrin glue. Usually these lesions do not, these surgeries do not have a problem of CSF leak, but it's always better to be safe than sorry. So, oh, I'm sorry, this is the wrong slide. I forgot to change it. That's it for today. That's a wrap. I will try asking Dr. Itzaz if we can do a Sylvian fissure splitting tomorrow, but that's not guaranteed. But let me know if you have any questions or any feedback. I'll try to get back, inshallah. Okay, no questions? It's okay, even if you think of a question later on, you can always leave it on the group and I'll try getting back to it. Thank you so much, everyone. This is a wrap.